Today's topic of discussion is hematuria. Every organ in the body has a language of expression when it is in distress and when it is functioning normally. So hematuria is a language of distress from the kidney, and it's an alarming sign both for the patient as well as the surgeon. Now, by definition, hematuria is actually presence of blood in urine, defined as presence of more than 3 red blood cells per high power field of a spun urine segment. Each word in this definition is very important. First of all, the blood that is present in the urine may be visible, in which case it could be either just a color or it could just be a gross hematuria. And it could also be only microscopic hematuria when only a few cells are present in the urine. But these cells can be seen better if you spin the urine sample and then see the sediment under the microscope. So like presence of 3 red blood cells per high power field of spun urine segment is what is the definition of hematuria. Now the shaper cells, the morphometry of the morphology of the cells, all this is important, which we will talk as we go along. And it is important to remember that even a very small quantity of blood in the urine makes the urine very red. For example, if you mix 1 cc of urine in a liter, 1 cc of blood in a liter of urine, even that will look very red. So what we see in the wards or in the OPD typically might seem very alarming both for the patient and sometimes even for the surgeon, but the quantity of blood may not be that much. But what is most important about hematuria is that it's got a higher chance of being a symptom of malignancy, particularly if it's a gross hematuria. And the color of urine itself should not be taken into consideration, because sometimes you can also find different agents which will produce hematuria. And for example, if you see fresh red blood, that usually indicates a lower tract bleed, say from the bladder. And if you see blood which is cola colored, it's probably coming from the glomerulus, because of it, during its passage down the ureter, it undergoes chemical changes, and therefore the color of the urine also changes. And the amount of clots, sometimes clots are present in the urine. The type of clots, the appearance of the clots, and the amount of clots are very suggestive. For example, if you find vermiform clots, it will suggest that it is coming through the ureter and probably therefore coming from the upper tract. On the other hand, if you find discoid clots, then it is quite likely that it is had time to settle down somewhere and come out, and that is obviously the place like a bladder. So therefore the shape of clots and the size of clots is also an indicator of something or the other in hematuria. And microscopic hematuria, which is visible only when you see the spun segment and the microscope, is also very significant, highly significant. And even though microscopic hematuria can also indicate presence of a malignancy. So it's important to know what are the different sources from which blood enters into urine. And this diagram is self-explanatory. We'll be talking about some of the causes through the use of this diagram. You can start from the top and go down to the bottom, and we can look at the various causes. For example, Alport nephropathy is a congenital condition and has a genetic origin, and that can produce hematuria. And there are easier ways of remembering the different causes. You could possibly classify it into congenital, inflammatory, neoplastic, and miscellaneous. So like now, if you look at it in that sense, Alport nephropathy is a congenital variety of cause for hematuria. Infections, for example, pyelonephritis, would give rise to that. And any kind of malignancy, either an RCC or a transitional cell carcinoma, that can also cause a benign renal mass, for example, like an angiomyolipoma, or for that matter, oncocytoma, can also produce hematuria. Any kind of benign renal mass, and very occasionally pelvic ureteric junction can also produce. And if there is a renal vein thrombosis because of any reason, or a navy malformation, or some kind of papillary necrosis will occur in this area. So some kind of papillary necrosis can also produce hematuria. So these would be the causes of hematuria coming from the kidney. So this is one section. The next section would be the causes coming from the ureter. So if you look at it in that way, again, malignancy is one of the causes, and sometimes strictures in the ureter or a stone lying there. Ureteric colics are often accompanied by hematuria, sometimes microscopic, sometimes macroscopic, and a small fibroepithelial polyp which lies in the ureter can produce the same symptoms. So this is as far as the bladder goes. As far as the ureter goes, now we have a segment which is bladder. We may discuss that along with the prostate. So if you look at it like that, bladder, one of the biggest and most important causes of hematuria from the bladder is a carcinoma in the bladder, which cancer could be a transitional cell carcinoma, for example. And very occasionally BHP can have blood vessels sitting on top of the dilated and on top of the enlarged prostate, and they can occasionally bleed. They were at one time known as vesical piles. No longer termed that way. But then just to give you an idea that they can also cause bleeding. And similarly, a cancer in the prostate can also produce a bleed. And now all these hematurias will have different characteristics. I'll go into it a little later. And urethral pathologies, either a stricture or a urethritis or even a diverticulum for that matter, because urine gets retained while the patient is passing urine in that, results in infection and further hematuria takes place. So this is the last source of hematuria. Sometimes it is not blood that is coming out, but it could be some other reason. For example, if you have hemoglobinuria or myoglobinuria, crush injuries, recently we had that accident in Uttarakhand, for example, and those people who are working would have been crushed, may have been admitted to hospitals, and then they can ultimately have myoglobinuria, and that also causes coloration in the urine. Beeturia, for example, beetroot, either eaten, even if you wash beetroot, the color of the water becomes reddish. So it also produces, if you take beetroot, that can also produce a coloration in the urine. And in women, and this is very, very important, if you are collecting a sample in a female patient, always remember that they could be going through a phase of menstruation, and that can contaminate the urine sample and give the appearance of hematuria. And some drugs too. At one time, there used to be a very commonly used drug called pyridium. This is believed to be an analgesic, and that used to be, most of the patients who would come to the OPD would have that color in the urine, most of the catheterized patients. Nowadays, we are not giving that as much as we used to give before. And similarly, we have many other drugs also. Another common drug which is used as a urinary antibiotic, like nitrofurantoin, that could also give a coloration in the urine. So always take the drug history of the patient also when you are trying to evaluate hematuria. So these are multiple causes and which for hematuria. And there's another condition which there are one or two conditions which I didn't yet talk about. One is schistosomiasis. Schistosomiasis is not very common in India and most common in Middle East. And this is one of the reasons for hematuria. And post-radiation hematuria, because bladder becomes very much thinned out and the mucosa becomes thinned out, and the vessels underneath the mucosa become very fragile and they tend to bleed. And this is very difficult to arrest. So this is a post-radiation hematuria. So look at the number of causes because of which hematuria occurs. And this is the reason why I said this is the language of distress coming from the urinary tract. So who are the patients who need to be evaluated? Everybody, in one sentence we can summarize that all patients who present with hematuria, either macroscopic or microscopic, they need to be evaluated to establish the cause. Absolutely important. Why? Because we don't want to miss a malignancy, and definitely we should want to find out what is the cause of hematuria. As I said right in the beginning, it's an alarming symptom for the patient and many times for the surgeon. Now, those who are on antiplatelet therapy or menstruative women or post-exercise hematuria, it is known that when we do a very vigorous exercise or even after a sexual activity, if a sample of urine is collected, then it does tend to show red blood cells. So therefore, we should rule out these causes before we collect the sample. So even infection, they should be evaluated after the withdrawal of the cause. Supposing if somebody has a urinary tract infection, he should first be treated, and then 6 weeks after the treatment, he should again be evaluated to check whether hematuria is still present or not. And asymptomatic microscopic hematuria will also be evaluated, even if there are no symptoms, because many of them show in the long-term evaluation that there is a calculus, silent calculus sitting, or maybe BPH, 12% of those cases, and even urethral stricture, 1% of the cases. These cases can also produce asymptomatic microscopic hematuria.